Our moderator today is Dan Walterman. Dan brings more than 30 years of healthcare experience. Dan has been president and CEO of Memorial Hermann Health System since 2002. He has also served as chairman of a lot of different organizations, and I'll name just a few: the Greater Houston Partnership, the Texas Hospital Association Board, Voluntary Hospitals of America Texas Board, 2011 National Seniors Games, and the American Heart Association Houston chapter. He's also received numerous awards, including the Texas Hospital Association's Earl Collier Award, the American Hospital Association's Grassroots Chairman Award, and he's been named one of the top 100 best healthcare leaders by Modern Healthcare magazine for 8 years running now. As a member of the Memorial Hermann System Board, I'm actually most proud of the leadership that he has demonstrated in terms of quality and safety. And we're the only hospital system or health system in the country that has won the top 2 quality and safety awards based on outcomes, actual hard data, not reputation. Joining him is Nick Augustinus. Nick is Senior Vice President of Health Information Services and Strategies for Cardinal Health. He brings 29 years of management experience developing and consulting in the healthcare arena, including development of various products. He led the development of Cisco's Care at a Distance platform. He was product development in charge of product development and clinical documentation for Computer Sciences Corporation, and he has served on a number of corporate and not-for-profit boards, including most of them in the healthcare field, Dexcom, Avera, Informatics, and a number of others, and he's currently on the California Healthcare Foundation Board. Also with us is Bruce Samus, and he is the CEO for Lockton Dunning Benefits. Bruce is a recognized thought leader in employee benefits and healthcare financing, and he brings many years of experience in aligning health and welfare strategies with corporate business objectives. He's currently focused on developing innovative service offerings and recruiting and developing the best talent. He previously served as Vice President of Employee Benefits for Cigna Healthcare. So as you can see, we've got a dynamic panel today. So please join me in welcoming them.
Thanks, Deborah. Good morning, everyone. Well, welcome to this panel on healthcare innovation and its impact on board oversight. As you can see from our pictures, I'm Dan, and I'm going to be the moderator. You can make me look very good and my job easier by sending in your questions. The panel wants to make sure we deal with topics that are on your mind and that you would like to bring back to your boardroom. With that, let me just put it a little in perspective. Healthcare is very complex, confusing, and one of your highest growing costs in any corporation. Why innovation today? Why all the movements and the noise around healthcare? It's simply this. We have a healthcare system in this country for the last 40 or 50 years that is very dysfunctional. And it's in need of transformational change. How we're going to navigate that change is a big issue in front of us as a country. Why is it needing transformational change? It's pretty much this one fact. On a per capita basis, the United States spends more than double any other country. Now, in and of itself, that's not a bad statistic if you were getting value for that spend. But the reality is, when you look at healthcare, what is value? Value is equated, are the people healthier, well, and in any statistic you look at. When you look at most of the data across the world, America comes in about 34th to 38th healthiest population. So we spend double on healthcare, but our people aren't any better off. Actually, we're pretty far down the list. So for the dollar spent, just like anything else in business, what is the value in return? And therefore, the value spent is not being spent in the right areas. Some of the issues here is that we really don't have a healthcare system. People say, well, isn't America's healthcare the very finest in the world, and this is the place you go? From my perspective, being in this industry in about 35 years, we have what I would call the finest in the world in one category, and that's rescue care. If you get ill, you're a diabetic and you go into ketoacidosis, you have a heart attack, you have a stroke, you're in a car wreck, we can rescue you better than anybody in the world. And you'd rather not be anywhere but the United States, and frankly, right here in Houston, the epicenter of healthcare. But that's not a healthcare system, that's a rescue care system. And we need to move more towards prevention and wellness. We need to have a system that's more engaging with the patient, him or herself, one that holds that patient accountable for their own health. And health insurance, the way it's evolved in corporations, is that we insure all our employees. Memorial Hermann's the largest private employer in Houston. And if somebody has an unhealthy lifestyle and they rack up a lot of healthcare costs, that's just averaged across all the employees, and everybody's premiums go up, even those that are keeping themselves healthy and well. So how do we bring in individual accountability? We could talk about a number of other topics, but those are some of the starters. And as you move forward, trying in a global economy competing against other companies, how does the cost of healthcare affect your ability to market that product across the world? When every other country's healthcare costs are a fraction of your cost. And so it's a challenge. How do we preserve the best of America healthcare while trying to get some value out of this system? And we believe that there's a number of ways to do it. We're going to touch on some of those. Technology, changing how benefits are done, how employers can interact with their employees, keep them productive and healthy and well. With that, let me just turn it over to the panel. I'm going to start with Bruce. Bruce is a CEO of a major health benefit solutions company. What are some of the things that you could recommend to boards to really look at to move from their status quo of healthcare and rising costs to this new world of healthcare?
Yeah, perfect. Thanks, Dan. The board discussion, first the management discussion, I won't go into that. You are all very well aware of that. I see companies approaching it in two very different ways. One is a more longer term view. Those companies look at things like health versus health insurance. The person who manages the cost on a year-to-year basis kind of looks at it as health insurance. And it's kind of like their car insurance. Every year, their corporate benefit program comes up for renewal. They open the envelope like your car insurance, like, what are we going to do? And then there's, and if the company has any size, the results may vibrate from year to year. But the line is moving up and to the right at a high single-digit clip because there's just certain macroeconomic forces in play that are going to cause that to continue to happen until we get some fundamental change. And Dan can address this better than I, but when the government doesn't raise their reimbursement rates, and they pay for half the health care, and if a health system needs a 3% increase, private sector's getting 6%. You throw that on top of that, the lifestyles and everything else, and you wind up in the high single digits. So from a board perspective, understanding that this is going up and to the right at that kind of clip is really the first and I think most fundamental. And understand it's a long-term fix, and that even though you may have a great result in a particular year, it doesn't mean that you've fixed the problem. And just one concluding comment. A lot of folks will say, well, our strategy is we use Blue Cross, we use Aetna, we use United Healthcare, and we have a managed care network. And that's what we're doing. We're getting discounts and we're channeling the people into these networks. Those networks have 99% of the hospital beds and 80+% of the physicians. Of the 10% of the physicians that aren't in there, 10% can't get in because they can't credential, and the other 10% won't get in because they got people like you in this room who will pay them fee for service. So, the strategy of we have a network and we're getting amazing deals, it's just retail. It's really not a strategy. Companies that are being progressive are going much beyond that.
Thanks, Bruce. Let me turn to you, Nick. You're a noted expert on innovation and technology. As you look at this large healthcare industry, what are some of your initial thoughts for board members on how they can move forward from an innovative or technology perspective?
When I think about technology, and I want to take one theme that you mentioned earlier on, that we have a rescue care system and not a health system. And the way I usually express it is that health is the destination, not care. So how we manage that and the role of technology in that is actually an interesting aspect. It's one aspect of technology. So one promise that technology brings forward right now, and we see it happening more and more, is an engagement of an individual in managing their health. And we can call it a proxy, we can call it a crutch, whatever you want. The fact of the matter is that there is some movement, if you want, of us as individuals to be more proactive in managing our health. And technology has played a key role in it. I mean, a lot of people nowadays wear Fitbits and whatnot. They measure their steps. They in some cases they compete with colleagues as to how many steps you walked and whatnot. All of this helps, but it's not the end game by any stretch of the imagination. There's another aspect of technology, something that I've been involved for quite some time, which is in the sphere of telemedicine, care at a distance, which again brings care at points where care does not exist, or most importantly, more effectively distributes care and matches supply with demand. I think that's the promise of telemedicine. On one hand, it brings care to people that do not have access to care as easily. On the other hand, it distributes it matches supply and demand in a more effective way and more efficient way than we do physically by moving people around. Another aspect that is actually, in my opinion, the biggest movement that we're going to see is the area of analytics and how we actually personalize care. So technology nowadays and information technology allows us to not only have someone's DNA, but most importantly, analyze vast amounts of data and trying to find causality in certain conditions. And it is a nascent science, if you want, but it's certainly very promising, and a lot of effort is being put against it. And we see the first signs of success with that. So a combination of artificial intelligence as well as our ability to manage and efficiently process vast amounts of data is going to be a game changer. So from this person's point of view, and this might be a little bit forward for me, if you want, in terms of what I believe, that in the very near future, the actual diagnosis of a condition will be almost a computational event. It will be a combination of imaging, of blood tests and various tests, which will be analyzed computationally and will provide an indication of diagnosis. The combination of that with the physician experience will allow someone to choose the best possible route for cure and for striving for health and changes that need to happen or treatments that need to occur. So I think the biggest move that we're going to see is in our ability to analyze and personalize care to the individual, and those capabilities are becoming much more affordable and much more common nowadays. You probably heard about harvesting stem cells when children are born and keeping them for potential future use. we can grow organs from stem cells, so that you can imagine what can happen. DNA profiling is something that is becoming more and more, full DNA sequencing is becoming much more affordable. It started to be in the hundreds of thousands of dollars. Right now we're probably at the $1,000 mark, and it's going down. So all of these things are going to change how we manage health in the future. But it's unavoidable that we as individuals need to engage and take better care of ourselves. In the absence of that, I think we're always aiming towards rescue care.
Well, thanks, Nick. What you've heard from Bruce and Nick in their early comments is a system that's really rooted in an archaic structure. And as board members, you have to understand that structure is based on a system of fee-for-service medicine. Fee-for-service medicine is just like any accountant or lawyer or plumber or electrician. You provide an episodic service and you pay a fee for it. And in medicine that worked, but to where today medicine is so complex with the technology and what's evolving, you really have to have an integrated structure. So the way we pay is what you get. And so why don't we have a health system instead of a rescue system? Because the payment under a fee-for-service system doesn't pay the healthcare system side, doctors, nurses, hospitals, to keep people healthy and well. Actually, if we didn't do the hospitalization or we cut back on MRIs, we would make significantly less. And so you have to change the incentives in the system. And that's what I'd like to take the next phase of this is how do we go about moving out of the fee-for-service incentive-driven system, and how do we start incentivizing the system, and in the boardroom you can do this, to get there. And I'm going to direct this one to Bruce. One of the things that I see from the provider side that has a trouble is that in a lot of board rooms that I go into as an invited guest, the board speaks of healthcare as more of a commodity to be purchased, you touched on that briefly, versus something to how to keep their employees healthy and well, and insurance is just one of the vehicles to get there. What advice could you give these board members today on how to move from that commodity thinking to be purchased to one that's to be managed and for their employees?
No, it's a great question. You've got to obviously balance the need to produce short-term, and I don't know if that's quarterly or annually, however you define it, whatever your situation is, results with long-term strategic thinking. And every organization has to balance that. I think where boards can be impactful is to encourage the company to change the way they look at it, the way they think of it strategically. I'll give you an example. It's one of the best statements I've heard at a board level, and I've used it all the time. I'm going to use it again. We were going through with this company who has a financial situation where they've got to take a couple $100 million out of their cost structure. They also have a very valuable and well-paid workforce. So the answer is not slash and burn, but they've got to take the $200 million out. So they've got the easel on the wall, and employee benefits are on there as a particular topic. They spend about $70 million a year. And we had put a whole laundry list of things that they could do, pretty traditional thinking. And we were talking about compound drugs. We were talking about some of the stuff Nick talked about. And that's, pretty intense things. We were talking about all kinds of things. And this board member said, stop. He said, do not turn me into Dan. I'm not, I don't want to be the one making these decisions. I spend $70 million. I want it to go to 60. And then I want it to go to 63 and 66. And at the same time, I want my employees to be healthier. I'm not I'm an employer. I make widgets. I do technology. I can't figure this out. Bruce, you can help us, but it's the healthcare system that we've got to partner with. They're my supplier. He said, hey, we spend less than that on steel, and the steel company is in here showing us how to rack the steel, how to cut it differently, how to warehouse it, how to have less inventory, what to do with the scrap. They're in here as our partner, helping us cut our steel costs so we can sell more of our product and they can sell us more steel. Why isn't the healthcare system in here with me? Why am I going through, necessarily an insurance company or an intermediary who's dumbing it down and trying to make everybody happy? I want somebody to make me happy. So I think where we will be is, and it's a battle for relevance right now. Memorial Hermann wants to organize the care. Insurance companies want to organize the care. Something you've probably heard of, exchanges, they want to organize the care, but in the end, I believe that it will be the health systems that organize the care, especially in markets where there are systems who are large enough and sophisticated enough to do that. And that's not a plug for Memorial Hermann. That's really how I feel.
Well, thanks. Nick, these board members need to help manage the cost, but also get more productivity out of their employees and keep them in the workplace, need to be competitive in their pricing. What innovation or technology would you recommend that they pursue to try to help manage that and enhance that value back to their corporations?
I think what I would start with one statement that I believe that today creating transparency, given the choice, and let me start with this, given the choice, a rational employee, given certain facts in terms of costs, in terms of outcomes, in terms of expectations for the treatment and so on and so forth, most people will make the right decisions, which includes a rational decision around cost. Unfortunately, the system right now is so opaque, and I challenge anybody to explain an EOB to the average person, or to challenge, how billing occurs and how, you, after hospitalization, get all these bills, and then the next thing you know, you get another set of bills, and then suddenly the bill goes up, goes down, some gets covered, some didn't get covered. It's just utter confusion. So understanding, creating an environment where transparency becomes part of the way that we deal with making these decisions around health is actually, in my opinion, will be a step in the right direction. And there are a lot of companies right now that are trying to create that transparency. Some of them has gone even as far as giving you preemptively the cost of a certain procedure, all inclusive, in order for people to make the right choice. Star ratings and quality ratings, of course, go into play, and I think as consumers will learn to manage this more effectively. So I would start with transparency. I would start with people making rational choices about their health, and most people would make the rational choices. So that's kind of the starting point, in my opinion.
I would agree with that. From my perspective, transparency is totally missing in the healthcare industry. If any of you happen, God forbid, walk out of here and have a heart attack and you go and get stabilized, but they said you need to go see a cardiologist for a next step, how would you determine who the best cardiologist in Houston, Texas is? Could you go to the internet and find their outcomes data? Could you find how many procedures they have done in a certain area that you might need? The answer is no. You might find health grades or somebody that says, here's how patients rate the doctor in terms of their customer service, but you won't find that data. And so how can you be an informed consumer if you can't even find anything about the system? How many of you can get an absolute cost of what it's going to, out of pocket, going to cost to go to a hospital or to an outpatient. It's just totally lacking. And the industry needs to come around to the transparency so that the individual is much more informed when they make a healthcare decision. Well, let's since this is an innovation title, I'm going to put you both on the spot here. Hot topic. The Affordable Care Act, innovation or not?
The Affordable Care Act, to me, was insurance reform. It did things to the individual health insurance market, such as take away the pre-existing condition limitation. It took away medical underwriting. So it made accessing that much more friendly. It also required employers to expand coverage for things like preventative care and other things. So there were changes. I don't believe, though, it addressed the cost of health care in the way it could have. And I also think it potentially stayed away from some things where I think we really could use the government's help. So I would give it a an incomplete grade because it only addressed the insurance side and not the healthcare side.
Okay, Nick, your thoughts?
I agree. Obviously, you have the expert here in the room. I agree with Bruce in terms of what the Affordable Care Act did. At the same time, I do believe that it is a process in the beginning. And in the absence of coverage, a lot of it becomes academic. And going back to Dan's comment, if somebody is not covered and they end up in a hospital, there's a cost associated with that individual. That cost eventually is going to be borne by everybody else that's covered. So I think coverage is an important component of it. I would agree with the assessment that through the process and we ended up with something that is incomplete, but it's a beginning and it's a journey, and that's how I see it. And by no means it's perfect.
Clearly a catalyst. It's also caused a flood of investment into the healthcare space. I can't tell you how many financial sponsors, will call, and I'll be all excited because I think they're buying a company, and we're going to get to do some work. And it's, hey, would you look at this package? We're thinking about making an investment in the latest technology, in the latest healthcare. So it has caused a flood of investment on the private side, and I think that will lead to as much innovation as anything.
Well, I appreciate it. I'm going to read a question. This one came from the audience here and asks me, has the ACA had a positive impact upon healthcare cost inflation? And secondly, how would you change ACA if you could? Now, if you read the media, there has been a positive impact on healthcare inflation. It's, for the last 3 years running, it's one of the lowest rates of inflation in the last 30, 40 years. But there's a little bit of underlying issues there. Most economists in healthcare will say that low number is more due to the types of insurance policies being bought, both on the exchanges, but also in companies that are trying to lower their cost of healthcare. They're going to more high deductible plans. And when you have high deductible plans, we're talking $3,000, $5,000, $8,000 deductible plans that we see all the time in my business. The individual that's earning middle income or less simply can't afford that first dollar out of pocket. And so they have insurance, but they choose not to use it. And that's a debate in the country. Is high deductible plans a good thing or a bad thing? It's debate in your boardroom. Should you be incenting your diabetics to get into the system and manage their diabetes versus, I can't afford that $100 test or procedure, and I'm going to put it off. And so that's one of the big things holding down healthcare costs is these high deductibles. People aren't coming in even though they have insurance. And then the second big issue that will bubble up is provider side. These high deductible plans are causing a real issue and bad debt. As a nonprofit institution, we will be very efficient in our collection policies, but we're not going to bankrupt any individual over healthcare costs. And so the single fastest growing expense on the Memorial Hermann books is bad debt. It's growing, $80, $90 million a year. Okay? These individuals simply can't pay. Because not only do they have a deductible, if they have a major procedure done unexpectedly, they also have a huge copay. So you take those two things, and it's just putting a chilling impact. Is that good for long-term health of people in this country? That's the question about these high deductible plans. And the ACA helps contribute that. The other thing is, what would you change if you could about the ACA? I think it goes along with what you heard from Bruce and Nick. The ACA is an insurance reform bill, not a health reform bill. If I was the one in charge, I would have not started with this bill. Insurance reform is absolutely necessary. It's important to get people with pre-existing conditions into the system and a number of other things. It does well. But you should not change and bring all these uninsured into a system that is at a high cost point and rising rapidly. What you should have done is gone in and reformed the health system, brought the cost per capita down, got the inefficiencies out of the system through true reform of the system, and then once you've done that, then bring everybody in a much lower cost point. What we've done is brought it in at a cost point that the government can't afford, both state and federal, to sustain, and private employers can't afford. And so we just continue the cycle, in my opinion.
Dan,
any comments you want to have on that?
Sure. So we've picked up tens of millions of people who didn't have insurance that are now on the exchanges. And there's still some debate on whether they were buying insurance before directly from Blue Cross and now are going on the exchange, or are actually newly insured. But when the dust settles, there clearly will be a lot of people that didn't have insurance who have insurance now. And so the theory was, if a hospital or a doctor didn't have to treat someone without insurance, they wouldn't have all that bad debt, because the bad debt's paid by, it's not paid by Medicare. Medicare, they legislate the reimbursement rates. It's paid by the private sector. That was my opening, right? If they need 3, you get 6, because either people don't pay or the payment's fixed by the government. So when people go out to the exchange, they see gold, silver, bronze, and the lowest cost plan's a bronze plan, and they've never had insurance and they buy it. Well, just in simple terms, a bronze plan has a 60% actuarial value, and you can arrange it however you want. But the simplest way to understand that would be about a $6,000 deductible plan, with then coverage after that, and maybe it will definitely have 100% coverage for preventive care. So that person who was previously uninsured, didn't have a doctor relationship, when they got sick, they would go into the emergency room, not the right way to access the healthcare system, hence the rescue care. So what's changed for that person? They have a $6,000 deductible, and they don't have a doctor. Guess where they're going when they get sick? There's no money for primary care, there's no money for drugs. They're going straight into the emergency room, they don't have a doctor, and boom. Now, if that turns into the $100,000 claim, the provider will get paid. But for, anything short of that, there really isn't that payoff to the healthcare providers, which really was the hope, right? That if we got rid of the uninsured. And then, I don't know if we want to put the Medicaid thing on the table. Here in Texas, if you're not, I guess, a child or someone who's expecting a child, it's very hard to get Medicaid, in our state. And that a lot of the expansion that the ACA has gotten in covered lives has been the Medicaid expansion. And that is an issue that we don't have enough time. And I can probably tell how this room votes, but that is an issue that is not going to go away. We have the highest uninsured rate in the country in Texas. We had, 1 out of every 4 people walking around doesn't have health insurance. Although 1 out of 5 drivers doesn't have car insurance, so I mean, and it's probably the same people. So.
Nick, any thoughts?
Yeah, the one comment that I'll make, and actually this is sort of the glasses half full on my side, is that the high deductible plans, for the reasons that Bruce mentioned, might not be the panacea, and certainly, for someone who earns $24,000, having a $6,000 deductible is probably out of the question. Nevertheless, I think there is one positive aspect of it. It creates an awareness. It creates an association with how much this thing is costing. And as we're in this awkward transition right now, and it is a transitional period, and I don't think that some of these things might be something of the history in a few years, but if you think about the role of the health savings accounts, and if you think about how we transition from defined contribution retirement plans to 401ks and whatnot that we, as society we have accepted, I think there is an opportunity here to start educating people and start people thinking in those terms and moving the needle a little bit. So for all their inadequacies, which I agree with Bruce's assessments and with Dan's realistic experience with what it means, I do believe that it creates a consciousness and an awareness, if you want. And I really think that in some respects, the health savings accounts, given that they're life savings, you can carry it with you, you can go from employer to employer, and ultimately it can be money that you put aside for retirement, I think will be something that we need to consider and kind of promote, in my opinion, with employees.
Sure, Bruce.
We've been agreeing, it's always fun to disagree a little bit. And I don't know if this is a disagreement, but I want to take that 401k analogy and play it out, because I hear that all the time. And I agree that a health savings account is a great thing for the right group. Our company, 3,000 people, white collar, educated, fairly well paid. It's the only kind of plan we offer. We offer one plan, and all we do is focus on health and wellness and how to be a better consumer. We take the insurance off the table. Everyone's got insurance, you're covered. If something goes bad, we got you. But let's, and I totally agree. But then there's a big slug of the workforce. And so look at the 401k. Yes, we got added defined benefit and went to defined contribution. But those early defined contribution plans, remember the original 401ks, they'd put that style box out with the 9 boxes, and then they'd offer 70 mutual funds and tell the employees, and here's how much you could save, and if you save this much, you'll have this much, and invest it and go crazy. So they'd undersave, and then they'd look and say, these are the best 4 funds. Well, they were all large cap growth funds, and they thought they were diversified because they bought 4 things from the same. So then we offered the employees individual brokerage accounts, and there it worked, like trading on their 401k account, managing it down to nothing. And so we gave them transparency, we gave them everything. So where have we wound up once that's mature? What companies are doing now is automatic enrollment. You're not going to decide how much. We're putting you in, and we're going to do step-ups. And you are going to invest. There are companies doing safe harbor plans. And what are we doing on the investment side? Target date retirement funds. Don't think. How old are you? Here you go. Well, we're going to rebalance. I mean, how many people ever rebalanced their 401k? Even if they followed the advice. Now, I know the younger people and the millennials and the phones, and so I might be off on that, but that 401k analogy, if you play it all the way out to where we've come 20 years later, we are right back to being, for the most part, very, very prescriptive. And it's probably not, again, for the people in this room or maybe the people that we employ, but for the large mass of workers. They've really, not restricted, but and people have the option, but people are staying in those funds. They want, do it for me. So anyway, who knows how it'll play out.
Well, one last thing for those who are on boards that have employees in multi-states, one of the things the ACA has done is not create a singular system of care in this country. It's really created 50 different systems of care. Each state does their own thing. Some have expanded Medicaid, some haven't, some have done different other things. So you have to navigate each state's issues as you're sitting on that board. And it's really complicating things as we move. Let me move forward with some other questions out. There's a few, I think there's 3 or 4 along the same lines, so I'll just use this one to tee both of you up. Will it be the government or major employers that will drive the transformation of the U.S. healthcare system? If it's major employers, what would you recommend how they go about doing it? Nick, any thoughts?
I happen to believe that to a large degree employers will advance the transformation of the healthcare system. The government will play a key role. The government, we cannot ignore it. It pays 57% of the dollars that are being spent, so it is probably the largest payer, if you want, of all, and that's including Medicaid and Medicare. But I do believe that the employers will play a key role in this. And what employers need to do, I think, is to continue educating employees and transition them to a more responsible health management and exposing them to the costs associated with it. And as I said at the earlier statement, I do believe that people given the right information for the most part make the right choices. So I believe that the reform it won't be exclusively from the employers, but I do believe that the employers will play a key role in it.
Yeah. There are some things going on with Medicare in and around start to pay for value. I think we talked last night, we all agree it'll get to pay for value. And so the government has been somewhat of a catalyst, but it will be employers who take a leadership role. But again, I don't believe that an employer can do it alone. It's the two people in the room when the care happens. It's the patient and the doctor. And if the employer is just talking to the employee, and by the way, if they're just talking to male employees, good luck. All the research says 75% of all the healthcare decisions are made by the spouse, the female spouse. So, we've got clients that are 80% male, and they do a fabulous job communicating to the males about changing behavior. So I don't even have to explain it. Now at a hospital where you got an 80% female workforce, you got a chance, right? Because you're actually talking to the decision maker. But behavior change is the holy grail. It's behavior change of the physician. It's behavior change of the person. It's when they get sick, how do they behave? But even better, before they get sick, how do they behave? And behavior change is really, really hard.
And I absolutely believe that it's the major employers, any employer should be driving this change. It's your employees, it's your productive workforce. There is a role for government. It's the safety nets where it happened in the mid-'60s. It's what we try to set up. Medicaid for the poor in any state, Medicare for the elderly. Okay, everything in between was built around an employer-based healthcare system. We've moved away from that with all this uninsured. There's a way to come back, but you got to fundamentally understand what's driving that. The industry for years was a wholesale industry. There's only 2 ways the providers got their business. It came through insurance companies that you as employers chose, and they help direct the employee into different providers, or it's the physician themselves send the patient. A hospital admits no patients, only a doctor. And so that model is breaking down, and employers should be looking at ways to cut out the middleman, contract directly with groups of providers that can show you that transparency Nick talked about in data of quality, safety, efficiencies, is going to share data with you every month. How many of you get the claims data from your insurance company on all your employees and data, analyze that to how you can help your employees stay healthy? How do you use it to segment your employees? Do you know all your diabetics? Do you know your hypertensions? And you can manage that. How many of you done things at the work site for healthcare? There are entities that, like Memorial Hermann, that will come into the workplace. We'll set up clinics if you got a big enough workforce there, a primary care doctor around the clock. We'll set up travel medicine programs right there so your employees don't have to leave. They can get all the shots they need. We'll do whatever it takes to make the workplace flow. And your most important asset is your employees and keeping them productive. You can't afford them to take off for healthcare. Why not bring healthcare to you? Why is it the old you have to go to healthcare? And so we have to have a different partnership. And you have to understand what the spend is. The spend is a lot in two areas. There's the middleman take and cut. What's the insurance company provide? This is where it gets provocative. If you're self-funded, they don't provide much. They do two things if you're self-funded. They give you they cobble together a network of hospitals and doctors. Well, the providers can do that directly to you. And secondly, they adjudicate claims. Well, if you also then change how you pay for health care, instead of having insurance and a fee-for-service system, you could go right to the providers and contract with a network at a fixed price per employee and have incentives. We do this with a number of employers. We go right in and say, show us your claim spend over the last 2 years. We analyze it. We said, fine, we'll come in and take every one of your employees at this flat amount. That's it. And if we save dollars, we get the first X percent. And after that, we'll split those savings with you. And you cut out that middleman, that 18, 20%. There's a savings right there. And you can start this thing moving down and having better outcomes.
If Dan can share in the profits, then you don't have to arm wrestle over what you pay for every service and how many services. Because back to that one person that I talked about the $60 million, he says, Bruce, I want the lowest net present value of my benefit spend over the next 5 years. That's what I want. I go, I mean, you don't want this little widget or this shiny object or this thing, number 8 on the list? He goes, no, I want the lowest net present value of my benefit spend without putting it on the backs of my employees. And by the way, I want you to be able to demonstrate that my employees close their gaps in care and get healthier, at least adjusted for age, over that time period. And if you can lower my cost and help my employees, like I said, close the gaps in care, get people to take medicine, get people to get their checkups, and demonstrate that they are healthier through real metrics, that's a winner. And I'll stop trying to figure out what's a compound drug and whether we should pay for 2 of these or 4 of those, and so different model.
It is actually a product of. There are many reasons why I contribute to this, but just to cut to the chase. Technically speaking, right now, theoretically, we can do it. Practically, nobody wants to pay for it. So the idea that data moves at no cost from one institution to the other to whatever the box in the sky kind of thing, it is actually flawed in a sense that there is a cost associated with it and nobody's willing to pay for it. And Memorial Hermann has paid it with the investment that they made to install all their electronic medical records and all the workflow systems and whatever they have to manage the health of the patients that they take care of. If I want a separate thing that holds everything, outside Memorial, then I have to be willing to pay for it, and I don't think there are many people that are willing to pay for it. Technology certainly has not made it easy for anybody. And in the days, remember there was about a few years ago, there's this big movement against personal health records. I actually subscribed to one of those, actually to both of those that were the prevailing ones at the time. One was from Google and one was from Microsoft. And I tried to bring together my electronic medical records for self-gratification, that I just see if it can be done. And I can tell you that I spent probably 6 hours on the phone with various entities, that from pharmacies to healthcare providers and whatnot. And at the end, I gave in. And I'm a little bit above the average Joe in my ability to manage that. And I just gave in. I said, this is not going to work. A shiny light in this, I live between San Francisco and Columbus, Ohio. And actually, my physician in San Francisco was able to connect my record with the Columbus, Ohio primary care doctor that I have. So there are some glimpses of that. But at the end of the day, it's not easy. It comes with a cost. Nobody's willing to pay that cost. And when it comes to us as individuals, managing that process, if you want, I would challenge anybody. A weekend watching a football game, playing with your kids, contemplating your navel, whatever it is, or doing my electronic medical record, I would poke my eye. I mean, it's just, unless you have a very serious condition and your health has become the center of your existence, I mean, at that point, you know, people with cancers know that T-cell counts know everything, because it's a life and death thing. From there on, I don't think any normal human being wants to endeavor there.
That's absolutely true. You also have a couple other problems. Even if a hospital system or a big doctor clinic did a very fine job of capturing your data and your records, there's no interoperability of systems. So if a Memorial Hermann system, there's a lot of acronyms, puts in CBC, that may mean something different. So your record goes over to, say you're up in New York City and you have an event, your health record's online, but they read it CBC, but in that city it means something else, and all of a sudden they're down the wrong track. It's what the country has not done is sit down and say, here are the common definitions, here's the interoperability standards that we need. And they've tried a number of times, as Nick knows, and we failed every time. So to really make this work, you're going to have interoperability, and you're going to have to cost. My suggestion on, instead of pursuing your own personal record, find a primary care doc that has a medical home concept, where they're going to help you navigate the system, help you manage whatever chronic disease you have. Most people, they get over 50 or got one or more chronic diseases. It could be, just hypertension or whatever it may be. Let them, and they're tracking that, and they can use these technology, wearable devices, whatever in the home. It's constant communication. Alerts go out. They can do a much better job, and there's a lot of doctors in this community and other communities that are primary care medical homes today that are practicing medicine different than what you saw 10, 15, 20 years ago. So there's lots of interest in the topic. Here's one that seems there's a number on this topic, and I'll just read this one question. It's all around cost and in some cases the outrageous cost of a particular procedure. So the question comes in, problem outrageous costs for certain procedures. A recent, I won't say what type of procedure, was billed at $250,000 for one night stay in the hospital. How is this justified? Who's making the money? And it's these kind of things that are breaking the system. Any thoughts on that?
Yeah, lots of thoughts. So there's a difference between billed and what gets paid. So you may have to look at it in context. Yes. So as a matter of fact, if you can find that person who pays the Dan's rack rates, let me know.
I'd like to know. Yeah. Let me know.
Yeah.
On the financial statements on that topic, and I'm sorry to interrupt, in the financial statements of the hospitals, if you see, it says patient revenue, and there's a number there, and then it says contractual allowances, there's another number, and then it says net patient revenue. And the disparity between the two numbers is phenomenal. And depending on how good you are, it might be half of the top line ends up at net patient revenue. So this is...
So if in very general terms, the lowest payer would be Medicaid, then Medicare, and then commercial insurance.
Uninsured's lower than all.
Yeah. Well, you get to bill them.
Yeah.
You get to bill them at the big number. You just don't get anything.
Okay.
But
that's fair.
Yeah. No. So yeah, uninsured. I forgot about 1 out of 5 or 10. Or I'm sorry, 10 or 20 patients. But anyway, so you've got the uninsured, Medicaid, Medicare, and commercial insurance. Commercial insurance is what we all have. That's the gravy train in the system, and that's what we're getting 55% discounts on, right? So you sit down with Blue Cross and they're like, "We got you 55% off." Woo! That's the network that's got every hospital and every doctor in it. But no one paid the big number. So I don't know the 250,000. What actually got paid? There also can be bundled payments. And just different ways you contract, and those are not all bad. Sometimes you'll go in and say, hey, for a knee replacement, the best way to contract is to pay a flat fee of $35,000, and some of those run less, some run more, but you have fixed costs. The provider's incentivized to be efficient, and if they are, they can actually make some money. You have a fixed payment. So we could just guess and guess and guess about the 250, but yeah, that's absolutely absurd. One interesting thing, though, that the data shows, when you call all that out, there are dramatic differences around town, though. You take the same procedure. Mm-hmm. So you got 2 hospitals, and the way they may contract with United Healthcare, one of the carriers, for the very same procedure, you will see pretty wide, different knee replacements, one, hip, spine, CABG. You've got an imaging. Imaging's the one that's most publicized, how you can, get an MRI, same machine, and it can be, hundreds of dollars or thousands of dollars for the exact same procedure. So I don't know if that's a good answer, but that 250 is just a crazy number without context.
Well, healthcare economics 101. It's very simple. Federal law requires that all hospitals and bill at the same charge for everybody. So I can't have variable charging for the same procedure. So you have all this insurance company that are negotiating with me for different discounts, as Bruce talks about, but I can only charge the bill that goes out one. So it gets out a rack rate way up here. Nobody pays that. I haven't found somebody yet that would pay that. And this thing is developed over the years as more, and this is a positive term, don't take it in the criminal term, a Ponzi scheme. It just compounds upon itself. Because as you got to understand, it's a highly cross-subsidy business. And so when you look at just that, and I'm going to bring you down, the uninsured, on a cost basis, not a charge, but a cost, a hospital like Memorial Hermann will collect about 8 cents of a dollar of cost. It's not zero, because there are some people that have assets that are uninsured by intent, and we do collect. Okay, so about 8 cents of cost. Medicaid, the system for the state of the poor, pays hospitals in this state 50 cents of every dollar of cost. 50 cents. Then Medicare, which is the elderly, the average hospital will collect somewhere around 88 to 89 cents of a dollar of cost. So we're subsidizing the government on that. That book of business, those three, uninsured, Medicare, Medicaid, make up about 62% of my business. Okay? So 62% of your business are paying you well under your costs, fully loaded costs. That leaves only one other sector, your sector, to make all that up. So not only are you paying for your own employees' true costs of that care, you're subsidizing government and a hidden tax. What do the average hospital charge entities, private employers, insurance companies? It averages somewhere between $1.45 a cost and $1.55 a cost. Now, as a nonprofit, what margins do I need to sustain myself for the interests of this community? I need about a 3% operating margin. So if everybody would pay their costs, not profit, just their costs, I could reduce my price to you all from that markup of roughly 50% over my cost down to, say, $1.05. So you could have a 50% decrease overnight. This cross-subsidy is what's killing you. And every year as the uninsured grow, I'm passing more out. There's no such thing as free care. Yes, they show up in the emergency room. Yes, the federal law requires hospitals to take care of them for free. Last year, Memorial Hermann did, on a charge basis, $1.3 billion of free care. When I negotiated with Blue Cross the following year, I'm just saying I know what that number is on an actual cost, and I'm saying I got to make that up, and I'm passing that on. And then they pass it on to you. And it just keeps going. And that's what we got to change the system. It needs transformational change. You got to get out of this crazy dysfunctional system that's like it's just spiraling to nobody can afford it, and it's going to cause bankruptcy. Yeah. Medicare is on the verge of bankruptcy. State Medicaid programs can't afford it. Where are we going with healthcare in this country? This is a better way. And I wish we had more time to do that. Any last comments as we wrap this up, as it's getting late from the panel?
I will pick on one theme that Dan just mentioned. One of the highest inputs right now into the healthcare system, or the highest input into the healthcare system, is labor. And it's probably 50% of the cost of delivering care. So the promise of technology here is that to some degree, technology can substitute some of the labor. It's not the panacea for everything, so it can substitute some of the labor by improving workflows, by substituting some repetitious work that occurs as part of the processes and whatnot. So there is a promise there. The other promise that I think we've tried it before, not so successfully, but I think there's a renewed energy around, is to provide care as we think about health as a destination and not care, not rescue care. I think providing care in the lowest modality possible, to the extent that the system is reimbursed for managing health, is going to be another element. So the home, alternative sites of care are becoming much more important in our discussions and are much more prevalent right now into how we construct benefits and how we think about the delivery of care. And technology, again, plays a role in there. We can manage patients, we can monitor patients much more effectively in home. We can do a lot of more things at the house that we couldn't do before. So I think there will be some changes there, but fundamentally the system needs to reform itself.
I'll give you two specific things and then some bigger picture. Right now, if we look at what's driving inflation, there are two things. The new specialty drugs that are coming online. I won't get into all the statistics, but it is absolutely shocking, frightening, what that is doing to the cost of employer-sponsored health insurance. These are great drugs that do amazing things, like the Hep C cure. I'll give you just a very quick example. We have a customer. they have a lady with a disease, it's passed on to the kids. I don't know the name of the disease. I can see it and I can't pronounce it, so I'm not even going to try to say it. But it starts out in your lower extremities. It comes up when it flares up. It happens every year or two, and when it starts to flare up, and if it gets to your throat, it can close off your throat, and it can be really bad. But there is a treatment for that, an episodic treatment. It's 15, 20 grand. So this family was costing this employer, let's say, every 2 years, everyone had one episode, 60 grand every 2 years. Came out with a prophylactic drug you can take. Never happens again. 400 grand per person per year. It's great. This family's never going to have to do this again and rush to the hospital and get this taken care of. It's $1.2 million. Employer's paying it, right? So these specialty drugs, the Hep C, 100 grand, you've got to have these are too short term. And the other thing is the frequency of large claims. The ACA took the cap off the top. Most plans had, we talked about this last night, $1 million max, $2 million max. I want to say this in the right way. I'm not saying care stopped at $1 million, but I think more rational decision making was made. Now it's unlimited. The incidence of claims over $1 million we've seen in the last couple of years, although very small, has almost doubled. I mean, the Hail Marys we're seeing, these are people that are not surviving, the millions and millions of dollars that are being spent. So in the short term, a strategy around specialty drugs and these mega claims is just, I think, an imperative for business. And then longer term, think about it differently. Think about it as health, not health insurance. Understand that, your big network is retail. It's not a network anymore. And look at it more from the perspective of I'm paying 70. If I could get someone to take it off my hands, a hospital system, whatever, for 60, for 65, it just depends. But when we've done this before, it's amazing what they'll take out of the system right away and no one notices. They'll change the prescribing patterns, they'll cut out the imaging. That first 8-10% to get them to that new basis, like this, it comes right off the top. There's just that much quick waste in the system. So it's hard, but with anything like this, there's opportunity, right? Before it was an undifferentiated benefit, the employees didn't appreciate it, and there wasn't a lot you could do with your cost, and you just kind of did it like your car insurance. Now, it's so complex. There's going to be people who do this really well and have a much better outcome, and there's people who don't, and the companies who do it well are going to have a competitive advantage over the companies that don't. So, if I'm sitting on the board or running a company, I'm going to say, I want to be in that quartile that does it the best. And I want this to be a cost advantage for me. I want this to be an employee advantage for me. With every crisis, there's an opportunity, and there's an opportunity to do better than the competition.
Well, let me just end with a few comments. As board members, I would go back and be pushing your organization for where do you get value in your healthcare dollar spend? Do we really know where those dollars are being spent? How can we get a better return by keeping our employees healthier? I would also go back, if you haven't already begun the analysis of what your organization is going to do when the Cadillac tax kicks in the Affordable Care Act. Because you're going to be faced, if you're a typical employer, with a pretty good tax penalty. That tax is a 40% penalty over the threshold that was set in 2010 and with no inflator. And so that's on top of the premium that you're paying on behalf of the employees. And you do have an option to opt out of insurance for your employees, pay a $2,000 penalty, a tax, I should say, and then turn your employees somewhere else. There's this whole concept of private exchanges we didn't get into that Bruce and companies like his know about, that the employees can have multiple options to choose from. There's HSAs. What are you going to do when that day comes? You just going to absorb another 40% hit? Or are you going to use that as a restructuring? That's an individual corporation decision, what kind of bonds you want with your employees. But that's a key decision that all employers need to be looking at starting now. If you haven't, I'd encourage you to do that. Lastly, there's lots of things you can do to improve health of your employees. As the panelists said, go look at those. Segment your people, understand what their health care needs and where your spend is, and build your program around that so it becomes valuable and no longer a commodity and expense on your books, but something that is truly an asset, your employees, that you can manage more effectively. So thank you for your questions. Thank you for your listening. And I know I can stay around a few minutes. There's a lot of questions we didn't get to. If you have some pressing, I'm happy. I'm not sure about the other panelists, but we appreciate your time this morning.
Thank you.